A SLAP lesion is a superior labrum anterior posterior lesion with or without involvement of the long head of the biceps. The lesion occurs between the 10 o'clock and 2 o'clock position on the glenoid labrum. There are 4 types, but type 2 is the most common. A SLAP tear leads to increased stress on the inferior glenohumeral ligament, resulting in a risk of shoulder subluxation and dislocation. A SLAP lesion occurs when there is a detachment of the superior glenoid labrum, when the local tensile stress and the glenoid labrum interface is greater than its holding strength. The pull of the long head of the biceps tendon during the cocking and/or deceleration phases of throwing is a common cause. The deceleration portion of the throwing applies a maximal principal stress, which coincides with bicep reaching its peak activity. The long head of the biceps is an important dynamic stabilizer of the humeral head, particularly during abduction and external rotation. So these things in conjunction can cause a tear to take place. It can also happen due to a compression force, such as fouche. It can also be a tractional pull, such as an eccentric tension on the biceps. During a SLAP lesion, there is very little to see. The patient will complain of a popping sensation in the shoulder, a clicking sensation, and generalized shoulder pain. Pain and limitation is found with overhead throwing and movement during the late cocking phase, where the chief complaint is pain. There's also limitations with elbow flexion in lifting objects. Overhead abduction will be limited, range of motion-wise. Special tests for the SLAP lesion include the O'Brien test. O'Brien test is also the active compression test. In this test, the patient has their shoulder in 90 degrees of forward flexion and 30 to 45 degrees of horizontal adduction with maximal internal rotation. The patient horizontally adducts and flexes the test shoulder against the examiner's manual resistance. The test is then repeated with the subject's arm in an externally rotated position. Pain and/or popping that's present in the internally rotated position but absent in the externally rotated position is indicative of a SLAP lesion. In the crank test, the patient is standing, with the examiner placing the distal hand on the patient's elbow and the proximal hand on the patient's proximal humerus, and then passively elevating the subject's shoulder to 160 degrees in the scapular plane. With the distal hand, the examiner places a load along the long axis of the humerus, while the proximal hand externally and internally rotates the humerus. Pain and/or clicking are indicative of a glenoid labral pathology. In the clunk test, the patient lies supine on the table. The examiner passively abducts and externally rotates the patient's arm overhead and applies an anterior force to the humerus. The examiner then circumducts the humeral head around the glenoid labrum. A positive finding will be grinding or clunking sensation. Finally, the grind test requires the patient lying supine on a table with the shoulder abducted to 90 degrees and the elbow flexed to 90 degrees. The examiner is going to apply a compression to the glenoid labrum while attempting to rotate the humeral head 360 degrees around the surface of the glenoid fossa. Positive finding will be grinding or clunking sensation. During manual muscle testing, you will find a decreased biceps function. Diagnosis is going to be clinical, and it's typically a diagnosis of exclusion. What's left? What have we been able to rule out? It can also be done arthroscopically or through an MRI, and treatment will require a surgical reattachment.